Everybody for showing up. This is really cool. So hopefully we can do more of these in the future. But this could be very informal, so stop me. I'm gonna throw some graphs up. If they don't make sense, I'll do my best to explain them. And, I don't have a ton of slides. I want it to be an open forum. So again, stop if there's a subject that sounds interesting and you want me to explain more. We've been talking about different subjects for the future too, so if something comes up you guys are interested in that you want me to try to explain in more detail at some point, I can do that. So I know a lot of you, but just an introduction, I'm originally from La Junta. I worked here at Spanish Peaks for 10 years as a lab tech, and that's kind of where I got interested in medicine, and in particular family medicine. And so from there, the journey began. I got into medical school and went to CU, and I did my residency in Denver at St. Joe's. So a little different demographic than what I'm used to serving here, but St. Joe's is kind of aimed at trying to serve in areas that are underserved and try to work on health disparities. And for any of you know, family medicine as a specialty, that's kind of its goal. I can joke around and say I'm jack of all trades, master of none, but family medicine really is, if you're trying to do put the biggest dent in health disparities and medical problems, that's the specialty people go into. It's one of the hardest ones. The training is quite extensive. I mean, you're treating all diseases. You get trained as a hospitalist. You get trained to deliver babies and take care of pregnant women. In fact, I'm going up to Fort Collins tonight to do a training in obstetrics, life emergency, obstetrical emergencies basically. Do a course up there tomorrow. But it's very spread thin, and the amount of training you try to get in a short amount of time is impressive, so that by the time you get to your job, which this is my first job without an attending over my shoulder, and I've been here for 10 years by myself now, so I'm 10 years in and still alive. But there's a lot of learning on the job from your patients. So most family docs are very appreciative of their patient population because they end up being a larger portion of their knowledge as time goes on than their original training was back in medical school and residency. So that being said, today we're talking about a subject that is mainly preventative, at least the strategies that I try to impose on my patients. But getting people to change their behaviors, their lifestyle is very difficult. The first step, though, is education. And so family doctors are very well versed in educating on topics where we can have a big impact. And this particular topic, I mean, this is the #1 cause of death in the world. #1 cause of death in the United States since 1950. And so it's a topic we blaze past a lot, but we don't realize its impact. I will pepper that with, we all have to die from something eventually. So when you look at statistics, don't be confused by the fact that healthy people get heart attacks too. They usually look different though. And so how we live our life, and the behaviors we adopt and the things we do over the years, particularly from the age of 30 on, start to accumulate statistically in a fashion that I want you guys to try to absorb here. Because we'll look at some graphs, but that's kind of the point is, it's like the plumbing in your house. When you start to accumulate damage over time, that damage may not be apparent in the first 2 decades that it's happening, but by the 3rd and 4th decade, the stakes get really high. And by then, when people are experiencing illness, their purchase on the problem is less. You have less leverage in changing those problems when they're already happening. And so think of all of that when we move forward on this. So a couple quotes. I mentioned that heart disease has been the leading cause of death since 1950, but also the leading cause of death worldwide. Thomas Edison, I hope this is his quote, I didn't mess it up. The doctor of the future will give no medication, but will interest his patients in the care of the human frame, diet, and in the cause and prevention of disease. And there's a lot of quotes similar to that family medicine really embraces. we are completely trained in treating disease after it happens. We're very good at it, and you guys know me, I'm also a hospitalist. So I work in the hospital, admit patients, treat them. So we take care of things after they happen. That's about, nowadays, more than 50% of my job, but we're looking for another position, right? I'm also the medical director of the clinic, so when I'm thinking about how we treat our patients, I'm thinking about our population, and I'm trying to work on policies in the ways we dole out medical care. That's going to have the biggest impact, and so this topic is a big one in a community like this where I feel like I saw a statistic this last month that Orfano County has the oldest average age patient than any county in the state, or it might be number 2. So we have a retirement population. With that, I discharged somebody from the hospital yesterday or day before. It was 102. So I mean, we do pretty good too by other standards. So little DeGrasse Tyson. The good thing about science is that it's true whether or not you believe in it. I think thanks to social media, sometimes I can't even start at this point. My first step for a lot of people is just convincing them that what I'm saying is true. Being a physician and being trained, I think physicians have 30,000 plus hours of training by the time they start their first job. You can only do so much if people don't believe you. So we'll start with this busy picture. So I wanted to start out talking a little bit about global health initiatives and global health. Withdrawing from World Health Organization was a big hit to family medicine. I think a lot of family docs are really having trouble sleeping right now. But mainly because a lot of our training in science is statistics-based, right? So there's a lot of information to gain from data worldwide. People experience disease differently in other countries. So heart disease doesn't look the same in a place where access to an emergency department and having a stent placed in a coronary artery within an hour and a half of your heart attack can actually happen in Orfano County. You line the cards up right, people can have massive MIs or heart attacks and suffer no damage afterwards, or very little, which is super impressive. That is unfortunately not the case in most of the rest of the world. So this is a really interesting part of a study, a very small fraction of information that's been collected since the 90s, I think 1990 actually. But I'm just kind of putting in a little piece here on global health initiatives that they are so important. Not only to try to level out the health disparities in the world, because absolutely that's important. We're the wealthiest country, and have so much to give other countries, but we get something from it too. We gain a lot of knowledge from knowing how disease happens when it isn't treated appropriately, at least in my opinion. Okay? What's the natural course of a disease? Every disease you can think of still has a natural course that exists to this day and age in a lot of different countries because there's no medical treatment for it. And we learn a lot from those folks, and they're studying studies on them. And so it's a two-way street. I think nowadays when people are really just focusing on us, I think it's important to keep in mind it's a relationship, and it doesn't give back the way we give. But it is two-way. There's a lot of information gained from other countries and the way they experience disease. So cardiovascular disease in particular, this is the DALY, Disability Adjusted Life Years, looks at basically 2 bits of information and tries to put it into some form of a statistic that we can wrap our heads around. It looks at actually years of life lost. So you had some form of event where your heart took your life. Okay, we all know what a heart attack is, but there are many other ways a heart can take our life when it stops working. So those are years of life lost compared to expected life expectancy of someone in that area. The other component that's part of this calculation is years lived with a disability. And disabilities not only affect someone's quality of life as that individual, but they also affect their community. Someone with a disability requires assistance from their community. They may not contribute in the same way, and it's important to consider how that shapes up an economy or a community or things that that are important to quality of life. So we look at that, and we look at the colors. The darkest blue has the lowest DALY, so you see like here in the thousands. And as you get lighter blue, you see more people, so in the thousands. So this would be like, for instance, we picked number 2,000 out of 100,000 people, where heart disease alone has impacted them. And as we shift towards dark red, you can see like just crossing, across the globe, a massive strip here. We've just got a lot of heart disease affecting people differently. And so, any information I want to share on this. So, for instance, in this particular study, there's 88 different risk factors that have been tracked since the 90s. And it's not just heart disease. You can look up other interesting things. So from the United States point of view, we have expert groups, Institute for Health Metrics and Evaluation, the National Heart, Lung, and Blood Institute, and the Journal of American College of Cardiology contributes to this data for our side of it. I think it's estimated, imagine a huge worldwide team of 8,000 scientists working together on this particular project, tracking health problems everywhere. That's an army of scientists and an unbelievable amount of education, right, to contribute to this. Any questions on this one? This one was important to me. I think it's really cool.
Yeah, the question on the previous point you made, and that is that since 1950 has been the leading cause of death. Any theory as to what occurred in 1950 to cause that change?
I think infections really become a lesser cause of death. Cancer. So those two medicine's really closed the gap. I would also say statistics, right? So the science of studying things, sometimes they get misrepresented because we just didn't have good data. But when you look at the data on heart disease, it becomes really strong. About the 50s, we started realizing, geez, what's going on here? Now, keep in mind, back then we didn't realize smoking was much of a risk factor, right? And it's the biggest one. And so our understanding of disease and basically taking that science and applying it changes what becomes our biggest enemy over time. And I would also say probably in the next 20 years, I think the landscape of cancer is going to change. Just because of what we can do now with genetics, how we can treat it, and learning our genetic code as a way of diagnosis has been something that will change things. But when it comes to heart disease, it's a pretty simple one, right? Like it's a problem with our vices. And there's some other things, but it is truly a struggle of our behavior. And so this is teaching people that it's a problem is the easy part. Then tackling the behaviors is quite an uphill battle for me. So,
Question.
yeah.
How do you account for like half of the U.S. not being blue?
So you got to keep in mind, like, I would personally, this is my guess on this question, is it's because our access to care is so good. So the majority of cardiovascular events end in something that we can fix if it's addressed within hours. So even down here in Huerfano County, our access to a heart stent, for instance, or just emergency department treatment if you had an arrhythmia, you can take a young healthy person with an arrhythmia, they're not going to last long if we don't do anything about it, if it's a bad one. And so if it's 20-mile drive to your nearest clinic that's open 4 days a week, don't pick heart disease as your problem, because you won't make it, But here, we talk about incidence of heart disease versus like disability. That's a whole different, that ratio looks totally different in one of these red places because we have so many ways of treating problems that are super effective, but they're time dependent and they're also resource dependent. But even in the US, like if you broke this out even further, just the state of Colorado, and we'll talk about this at the end, your zip code makes a difference on your heart disease risk, even in Colorado. So Broomfield, Cherry Creek versus Huerfano County, Crowley County, huge difference. So, and you can say, well, what about access to care? It's like, how many patients per doctor are in Huerfano County versus Cherry Creek? Blow your mind, right? There's 2 full-time primary care doctors in this county. I know one of them. You know, it's like, it's pretty, it's not that we don't, and then when you're in, you know, that's like one disparity of care. I would say that we're very lucky, on the other hand, that we have like the facility we do. It's pretty rare to have a facility with that many resources in a population this small. It's just spread out, I guess, so. Any other questions on that one? So the next one's kind of a similar, this is the same group, but breaking things up by the type of heart disease. And so here's a list of a lot of cardiovascular things that could go wrong. And if you can hone in on the salmon or pink colored one, that's ischemic heart disease, which is pretty much what we're dealing with today, what we're talking about. And so high income North America is this bar here, and you can take that and put the entire bar inside the pink all the way to the left. And so, again, you hear a lot of information about where the sickest, the wealthiest country in the world, right? It takes a lot of resource to keep that country's bar that small. And it takes no resource at all to let it run wild, you know. And that's, you know, a big topic nowadays, social determinants of care. So, yeah. Any questions on this one? This is a little not as intense as the last one, but it's just, I think what I'm trying to get across here is heart disease looks different depending on where you live. Isn't that wild? And it can't all be explained by just your diet or something like that. So, let's see. All right, so this is pretty simple, but I just want to briefly kind of go over all the topics everybody knows about. I didn't want to hit this too hard because it would get boring for you, but on the left side are things that we can change. So, tobacco, don't smoke. It is the highest risk thing you can do. That includes cigarettes, vaping, chewing. They're all bad for the heart. Secondhand smoke is also very bad for you. And out of all the things that we can do, it's also the hardest one to stop. It's more addictive than heroin. You know, it's terrible. I think the campaign against smoking finally won, but I still see people that are young starting smoking, and that's a bummer because it's really hard to quit. I also put out there that there's plenty of information that quitting at any age is still beneficial. You know, I have a lot of patients who come in and they're, you know, 6th decade of life, and I've been smoking my whole life. What difference is it going to make now? A huge difference. It's a cumulative change, both for cancer and heart disease risk. So, yeah, we hit pretty hard on trying to get people to quit smoking. So diet. This one I won't go into too much detail, but a healthy diet's really important, I would say, for many reasons. The big one is metabolic syndrome, which includes diabetes, hypertension, all the things that really affect the heart. And I guess my other big advice, just from being a clinician, is don't go to social media for your dietary advice, because it's amazing what you'll find there. Good old-fashioned Mediterranean diet still wins when it comes to real science, you know. So lots of fish, healthy vegetables, healthy oils, low processed foods, low carbs, you know, it's. And another thing I throw in there, and you guys many people here have already heard me lecture you on fasting. Time-dependent eating or intermittent fasting has a lot of health benefits, mainly because of an item we're going to come across here, talking about managing blood sugar, which is essentially what we're talking about is insulin resistance, but we'll get to that. So activity, we're very sedentary people in the U.S., and our bodies are designed to move, burn energy, and then fill the tank again, not leave fuel in the tank for years. One thing I think about is our bodies are set up to feast and famine, not feast, feast, feast. We have the way our hormones work, the way our body stores food as energy. It's made to fill up and then empty the tank, and fill up and empty the tank. If you fill up and you empty the tank halfway and you just leave it at half full all the time or 3/4 full, your metabolism starts to suffer, and the way we respond to those hormones starts to suffer and get deranged. When we talk about exercise, there's some interesting studies. They don't include a lot of people. They're usually, I think these studies are just over maybe like men in their 40s, but the most recent ones I think that are interesting are basically like, well, how much exercise and what intensity is important. And out of all the studies, moderate intensity is the most impactful. Really, really intense, like just destroying yourself exercise actually is not as effective at reducing heart disease as just moderate exercise. So brisk walking, sports that don't involve like, just hours on end, lots of muscle soreness, that kind of thing. So we're talking like ideally 3.5 hours a week of walking, like just brisk walking. And then, the pattern of going out and trying to exercise and then falling off the wagon for weeks and then exercising 3 days hard, and then as opposed to just going out and walking the dog, So it's like something that's pretty interesting, that it's probably easier than you think. Alcohol use. Lots of really misleading studies in the past on alcohol, but really no amount of alcohol is healthy. If you look at World Health Organization and the studies they put together in the last 10 years, any alcohol use is not healthy. So if you drink, stick to a drink a day or even a couple drinks a week if you can pull it off, or don't drink at all. Also, even though we're not talking about it, alcohol is a pretty decent cancer risk, so if you use it every day. Another one is sleep, which everybody overlooks, including me. 7 to 8 hours of sleep a night really reduces, it has a direct correlation to reduce cardiovascular disease risk. Probably due to stress and cortisol levels would be my guess. But also we make poor decisions when we're tired, when it comes to food and exercise. Obesity, best measured by your BMI. A lot of these things kind of go together, obviously. Hypertension, so I'd say the biggest thing is just be aware of your blood pressure and treat it if it's high. And then the question is, well, what's high? Well, it kind of depends. So a couple things on high blood pressure and high cholesterol. We have really changed the treatment of those based on your risk, and we'll do some risk assessment in the end here, where you can even see like how we might change the recommendation from one patient to the next in regards to blood pressure based on their other risk factors. If you're a diabetic smoker with high blood pressure and 20 years under the gun before you started treating all those things, my recommendation for you is going to be the old 120 over 80 or less. But if you're an otherwise healthy person who came in and you've got a blood pressure in the 140s, we're going to try to get that top number under 130. And so things are getting a little more data driven as far as how we treat a specific problem. Insulin resistance, I could go off the deep end on this one. I definitely take side quests on diabetes all the time. This is one of those where we test for with the blood. Insulin resistance ultimately becomes type 2 diabetes. More than half of my patients I see in a day have diabetes, which is pretty impressive. It is a very costly disease in the United States, and it also makes big pharma very rich. My approach usually is natural at first if someone just got diagnosed, but I usually hit them up with intermittent fasting. That's my initial approach because it has some very, you can impressively reduce A1C numbers very rapidly. We're going to talk a little bit about that in a little bit. So those are any questions about the things that we can change? I think everybody knows about all these, but...
What constitutes fasting? How much time must one eat to be considered fasting?
So definition of fasting is we become a little ketotic. Our body switches from breaking things down, and it differs on the person, But essentially, to become fasting, you have to get through what are called glycogen stores. Glycogen is your short-term energy storage, and what it really is just a bunch of glucose molecules built into a bigger molecule that looks kind of like a tree. And meaning that the glucose at the very base of the tree, if say you're a guy who's gained a couple pounds a year for the last 20 years and you've never fasted, the glucose you stored at the base of that tree could be 20 years old in your liver. So the liver holds a fair amount of glucose by this glycogen stored muscles as well. So muscles need it because they're in rapid activity, they need to break that down immediately, have it like literally in the cell. Versus your liver, it's got, depending on the person, 1,500 to 2,000 calories built up of glycogen store. So that'll run an active person less than a day. So most of the time, if you're not overeating or you're not going to bed on a big full stomach and you've been active that day, you'll be in somewhat of a fasting state even by the time you wake up. So when we talk about intermittent fasting, we're more, kind of like the very beginner's intro to that would be, skipping 2 meals a day, 3 days a week. So eating dinner the night before, not eating until dinner the following night. And then the next day you just do whatever you want to do, right? But building those little fasting periods in can really teach your body to be insulin sensitive again, if you're starting to become insulin resistant. But it's also very effective at losing weight, helping you lose weight. It's a good question, but yeah, it can differ. You can set a time, but if one person has a ton of glycogen stores, then it might take them longer to become fasting by not eating. The snack and beverage industry in the U.S. is just super robust and very brutal. And that's, you can attribute a lot of diabetes to that. Just people trying to make money. So, non-modifiable, won't put too much on this, but I get questions sometimes about menopause. And menopause, what's interesting is like heart disease risk for men is pretty much high compared to women their whole life until women hit menopause, and then their risk starts to approach that of men. Mainly due to hormones, thanks to testosterone. But there's things that affect women's cholesterol and high blood pressure, particularly hormonal, once they start in menopause. And so that's where that one comes in. When we say non-modifiable, and yes, you could say replacement hormone therapy, but there's risk and benefit there. So, race is one I think is really interesting. You go back and look at studies, and we made a lot of big assumptions about race, many decades ago, until we started studying social determinants of health. So there are many studies showing that black individuals generally experience higher burden of heart disease compared to other racial groups, primarily due to a higher prevalence of risk factors like high blood pressure, obesity, diabetes, all of them linked to social determinants of health, like their access to quality health care and education, nutritional disparities, rather than an inherent biological difference, which has literally been the teaching for many years, which is kind of, I'm glad we're getting to the bottom of that, but again, when you see racial disparities in certain disease states, it's almost always because of these social determinants of health, and a lot of times, namely zip code even, can make that difference for somebody. So. Any questions on this slide? It'll be good. Still awake. All right, so this one's pretty intense. So this is a tool we're going to use at the end of the session. This is just a part of that tool, or kind of playing around with it. So the American Heart Association has put together for many years data and trying to use that data to actually be able to provide a patient with their risk in a meaningful way. And so there's different ways of evaluating and presenting this data to people. The most meaningful they've come up with is to say, hey, are you between the ages of 30 and 79? Do you want to know what the odds of you having a heart attack in the next 10 years is? And that's what they can tell you. How about the next 30 years? How about we play around with these different numbers? We change this, we put you on a blood pressure medicine. You stop smoking, we treat your diabetes. Let's look at your risk now. Okay, that's what's going on with this slide. This is the American Heart Association Prevent calculator. You can see it up there. If you want to get at this at home or on your cell phone, you just put in AHA Prevent calculator, and it'll come up for you. And I'll bring it up today, and we can put in my numbers and play around with them or something. So, it's looking at all the usual suspects. I mean, you can see the list of things here, and there's many more on the list you can enter. What's important is that it doesn't. Everything it looks at has been validated, and I can only assume the new calculator that's available right now, which has only been online, I think, for less than a year, there's got to be some help from AI, because it has gotten so much better than it used to be. But this is metadata, meaning that many trials put together, hundreds of thousands of patient years of data going into this, clear back to what was called the Framingham study, which was the original attempt at telling people what their risk was. So in this particular one, just to kind of show what this is saying here. So if we look at just these three columns, you can see that this is all female. So this is the red bars, or this person's risk factor for 30 years versus 10 years. So we're taking three separate females, all age 55, giving them the same information through all these risk categories. Okay, and let's do that real quick. Total cholesterol, good cholesterol, systolic blood pressure, BMI, kidney function, diabetes, smoking, blood pressure prescription. So if you have high blood pressure and you're on a blood pressure prescription, that bodes worse than if you don't have high blood pressure and you're on a blood pressure prescription, which is worse than not having high blood pressure and not being on a blood pressure prescription, right? Statin use. So same thing. You still have high cholesterol and you're on a statin, right? What happened before we got you on a statin? Down here is a different measure of kidney disease. And then hemoglobin A1C is how we diagnose and track diabetes or insulin resistance nowadays. So the only difference between these three ladies here are, here we have on these two columns someone with a little bit of protein loss in their urine, and this person barely has diabetes. So 6.5% and above is diabetic, this person's 7. And you can see how that affects both 10-year and 30-year risks. And this will be more fun when you guys can go play with the calculator and change things about yourself. As you move on, you can see we're just adding 10 years to the group of the 10-year and olders. But a lot of these things, well, actually we changed blood pressure here and made someone more obese. But we changed some factors you would expect to maybe have a bigger impact. And really keep in mind, this is 10 years from age 65. So this was 10 years from age 55. So this person already made it through this bar before they got to this one. Does that make sense? Then we get into men. And you can see these numbers, how they're comparable to those groups, and how everything just gets shifted a little higher, thanks to testosterone mainly. But a 55-year-old female with these characteristics, that's pretty healthy overall, compared to a 65-year-old man with not huge changes, HDL is 10 points lower, right? But diabetes is pretty solid here, 8%. And we're talking a 10-year risk. So if this was me at age 65 and there were 4 of me, one of us is going to have a heart attack in 10 years. Does that make sense? So, any questions on that one?
Hereditary, does that fit in?
So absolutely. So genetics plays a big part in it. So family history of heart disease is huge. And then also, what decade of life? My grandpa had a heart attack age 85, he smoked his whole life. My grandpa had a heart attack age 45, he never smoked, and he actually was really into bicycling, he's never overweight. Really? Do you have high blood pressure? I'm not sure. Okay, paying attention to that, right? So those, when you hear that the genetics is a big component, we might be more aggressive in trying to determine your personal risk. And we could talk about in addition to these things, what else can you do to determine your risk right now? You know, so any other questions on this one?
Not sure if authors did you in reverse, but it seemed like it did. When you're talking about the, they say no high blood pressure and no blood pressure medicine is better than.
Yeah, not insinuating that blood pressure medicine is bad for you, but just saying when you look at these, what this is trying to show is there's basically, you can group things out as, my patient has normal blood pressure and they've never been on blood pressure medicine, that's great.
Okay.
My patient's on a blood pressure medicine and their blood pressure is normal, cool. My patient's on a blood pressure medicine and their blood pressure is still high, you know. And so you don't, when you hear that, it's like, it's kind of like when you're purchasing a car from somebody and like, I got all the records right here, man. Change the oil every time, took it to this place, here's all my receipts, whatever. Versus, yeah, you know, I try to keep the oil changed in it and you check it and there's no oil in the dipstick, or, you know, that's different, right? So somebody comes to you and, yeah, I didn't really engage healthcare until I was about 55, and when I did, I found out my blood pressure was like 170 systolic, and you're like, ooh. So that person could be hiding some pretty significant risk. And same as with statins. You know, statins and blood pressure medicines on social media get a terrible rap. I can, and you know, like, I can never convince people of the things they see over and over and over, even though I can show them the data and say, you know what, if it were me, you know, this is what I would do. But, you know, part of my history taking on a patient is trying to determine, am I getting involved in someone who has all the maintenance records on their car, or is this someone who really doesn't know, and at the time that they first went to the mechanic, things were a mess. You know, and so it's the difference between a car with 30,000 that was never taken care of and something with 100,000 that was immaculately, you know, cared for. It makes a difference, and that's what's, you know, in the very beginning I was saying, try to imagine this data, you know, third decade of life, fourth decade of life, you can get away with a lot. Fifth and sixth and seventh decades, things stack up pretty rapidly, and you can see that data reflected. Any other questions on this one? Yep.
Pre-diabetic, what does that really mean?
Pre-diabetic just means insulin resistance, and I'll get in more detail now on the next slide. I gotta avoid that one a little bit just because I go off the deep end on it. I don't know why, but I love diabetes. It's bizarre. I didn't think I would, but let's take some guesses as to what the first picture up there is. These all have to do with their category, by the way. Any idea what that is? It's a cross section of something.
Blood vessel
Yep, it's a blood vessel.
and fat.
And it's this is a transmission electron micrograph that's been fake colored to sort of represent the different parts of the blood vessel. So this is a coronary vessel. And it's important to know a little bit of coronary anatomy to know like how, like, you know, I don't know how many people in this room could answer, is like, how does high blood pressure cause a heart attack? You know, what's happening? You know, and it's kind of hard to put together if you don't know a little bit about the anatomy and how it works. So we look at this picture, the black part is the intraluminal space. So we're looking at a vessel that would be, you know, pretty big. Red blood cells, white blood cell, but this is potential space. But if we look at this really thin layer on the top here, the green, that's the endothelial layer. And it's engineered to be very slippery. Okay, so this only exists in endothelial cell, or in blood vessels, whereas endothelial layer that tightly locks cells together, very slippery, very hard to form a blood clot on, very hard to block off. Things just want to fly through, right? As we go further, this is smooth muscle, so the red part's smooth muscle. So it's like muscle in the artery? That's interesting. What's that for? Well, our arteries are contractile. They can actually constrict. So everybody knows cocaine's bad for your heart, right? Well, when you do cocaine, that smooth muscle constricts. And if you had a little bit of blockage, you have a lot of blockage. And that can actually form a blood clot. Or if it's bad enough, if you be a young, healthy person and you're just really susceptible to the effects, that coronary spasm can be so bad it actually cuts off circulation to a portion of your heart while that cocaine's active. So that's why cocaine can cause a heart attack pretty quickly. especially in a diseased person. But it also is, so there's reasons for that smooth muscle to be able to contract, but over time it can chronically get more toned so that it actually restricts blood flow chronically. Okay, so that's another disease state. The other thing you'll see here is this yellow part. The yellow part is very elastic. So, thinking of young healthy coronary arteries almost like a rubber tube that can expand, and as your heart beats, we have a lot of blood vessels. The aorta is another one that actually distend upon being on their filling and then slowly, squish back against that pressure so that you can have almost like a pressure reservoir. The aorta is very expansitile, so as your heart beats, the aorta beats with it. And so that's so that when we measure our blood pressure, if you're looking at the waveform of the blood pressure, it does this, right? If you didn't have that, it was just rigid piping, like we had a PVC coronary artery, it would be like, all pressure, no pressure, all pressure, no pressure, because our pump isn't continuous. And so, because we need the system to be like that, if you have high blood pressure, that pressure wave is much more damaging. So that the stretch on these muscle cells and this elastic tissue is to the point that it starts to damage it over time, over millions of beats. So imagine like an old hose out in the sun that got cracked. It allows scar tissue to work its way through and eventually here and there replace some of those endothelial cells, and all of a sudden you don't have this really slippery surface anymore. And the more scar tissue that forms, the less expansitile it is. So its performance gets reduced too. But over time, it gives a place for a plaque to form so that your cholesterol can stick to it. Over time, cholesterol then can form calcium deposits, so you're starting to take something that was once really slippery and elastic, making it rigid, and actually putting deposits on it. So the exact opposite of what its physiology was supposed to be in the first place. And those plaques can get upset, angry, and they can rupture. And then when a plaque ruptures, that's a type of heart attack that's hard to come back from. Because it goes all the way until it hits a point in that vessel it can't pass anymore and it blocks the whole thing off. So when a cardiologist is going in there, or an interventionalist is trying to open up, they can't get anything past the plaque. It's already lodged as far as it will go, right? Versus like an area that's starting to get blocked that you notice because you're just having some chest discomfort when you exercise or climb the stairs or you're short of breath, something's not right. They go investigate and yeah, there's a narrowing there. They can get past the narrowing and open it back up with a stent. So that's hypertension. This is damaging the kidneys, and we will cover that when we get down to this guy here. So, all right, what's the next picture?
Unhealthy cholesterol.
That's one of them. So there's two forms of cholesterol there. Do you guys know the two main types we look at?
HDL and LDL.
Very good. Is there an easy way to remember which one's good and which one's bad?
H is for happy.
I like it.
That's a good one.
I tell people you want your H to be high and your L to be low. Even though HDL, which one do you think is which in this picture?
HDL's big. Yeah, let's hope so.
And then, assuming that's right or wrong, I don't know yet. Which one? What are these little guys here? That you see something else associated with it?
Oxygen.
Type of protein. So cholesterol is a fat, right? And we're water soluble. So to move fats around, we have to package them in a way that our blood can transport them. So it's like the UPS, but like you also have to label them for where they're headed. So even though HDL is called high density and LDL is called low density, LDL particles are actually bigger. So the big one's LDL. And think of it like this: HDL is like a tightly packed ball of yarn, while LDL is a larger, fluffier ball. And it's easier for the cholesterol to come free of that LDL particle, but that's how it's designed. We weren't designed to have too many of these floating around. We're designed to have just enough and efficiently transport this fat. But overall, the LDL takes up more physical space for the amount of fat that it transports. So another way to conceptualize this is HDL are like tiny garbage trucks, and they roam around your bloodstream picking up extra cholesterol and take it back to the liver where it can be processed. So that's the direction you want the fat to go. LDL, they're like delivery trucks. They're taking this cholesterol to places where it's needed, but it drops a little along the way. You know, does that make sense?
Why is there an upper limit on HDL?
What do you mean by upper limit?
Well, when you get your results.
Oh, why is it abnormal if it's above 70?
Exactly.
Okay, that's an interesting topic. So that's still being studied right now, but we can show that your HDL is great to keep going higher until it gets past 70. Then it's probably because anything greater than that represents a different type of HDL that's dysfunctional, basically, and doesn't look like that tightly packed ball. And so, and a lot of times that's familial, meaning like you inherited it. So yeah, my mom's LDL was 110. Weird, right? And it's like, that's not good. Yours is high too. Does your mom have any heart disease? It's like, statistically, LDL will always confer a benefit to your cardiovascular disease risk. So the higher it goes, the better, until you pass 70 or somewhere around there. And so as a patient, what do you do with that? And it's like, that's a tough one. My approach, I mean, again, I was actually just talking with our cardiologist about this, like if there's anything new. My approach is to start with statins and see if it helps. If I get a person on a statin and the ratio of their LDL and HDL actually gets worse, and the HDL climbs even higher, then I get them back off the statin. And I look at other risk factors. I'm always reassured to hear, I know my mom had cholesterol just like, it was like, my mom's doctor told her it was the highest cholesterol, HDL cholesterol he'd ever seen, and she didn't have any heart problems. It's like, okay, not everybody's the same in this category, and there's a lot of different variations of why that HDL can get so high.
I've heard that the ratio between HDL and LDL is important.
It is.
Can you give me some?
So a good example of how that might affect what we do. So, many of you who know me know that I'm not really heavy on medication unless I feel like it's really going to make a difference. I don't want to just put a bunch of people on medicine like, oh, there's this diagnosis, that means we need to take this. And one of those is cholesterol. And so I use this to determine someone's risk, but at the same time, looking at that ratio. So if a person has no other risk factors, they've got a pretty clean family history, but their LDL is a little on the high side. It's like 130, let's say. But on the other side, their HDL is 65. I'm not going to recommend doing anything. But you can use this risk calculator to punch in different numbers and see that, the likelihood of that statin improving your long-term risk, it's very low. Like a lot of times it'll be like the 30-year risk difference is like 3 to 4%. And a patient might find that meaningful though. It's like, 100 of me and 3 to 4 more are going to have heart disease when they wouldn't have had it. Give me the statin. Okay, sounds good. Most of the time that I'm pushing a statin, it's going to be for a risk greater than that. And not because statins are dangerous, but every medicine has some side effects. Even if they happen 1 out of 30 times or something, whatever it might be, I'm also playing that risk game in my head and the patient might say, you know what, if I get muscle soreness with my statin, I'll stop it. Okay, good plan. Let's reduce your risk a little more. Sounds good. It's not going to hurt anything. If there's no bigger risk factor than anything I've discussed today, if you've already proven that you can have heart disease. So if you've already had a heart attack or you've got a calcium score that was really high, when we talk about that, or you ended up with, you've had, any imaging that suggests you've got atherosclerosis, like within your aorta or something, we get more aggressive regardless of these numbers, because that's a different scenario. Like this, you have to totally acknowledge that this is not the whole picture. We're doing our best with the risk factors that we can identify right now, but who knows what the tests will look like in 30 years, you know?
My doctor, he told, I wouldn't take a statin. I just kept telling him no, no, no. He finally said, if you'll lick this, it'll do you some good.
Right.
And I said, okay, so he said, take it. I said, what's the least I can take it?
Yeah.
And he said, maybe every other day,
Mhm.
and just the lowest dose.
Mhm.
I'm wondering if I did if my body can kind of adjust to the statin at a low rate like that, maybe I probably will have to build it up at some time, like more.
Yeah, statins are one, like if you have a side effect to it, it depends on the side effect. And so the big issue with the statin that people have is that they're worried, they go look up side effects. And I'd always say with any medicine, when you're looking up side effects, understand that this is a very litigious country we live in. And those pharmaceutical companies just don't want to be sued, understood? But at the end of the day, their side effect lists are just ridiculous, right? So they'll do these studies. They have to have so many patient years when they test the new medicine out, and they produce correlation studies, which it's not really good science. So a person who takes a medicine like a statin, for instance, their only risk factor is usually not just their cholesterol. It's hard to tease that out, right? They have all these other medical problems sometimes that create their own symptoms on it. So if I say, I got 100 patients I'm going to test this new drug on, and if I did not initiate that drug in those 100 patients, in the next year they're all going to complain of random things that didn't happen to them the year before. And so correlating that with the drug is what we use placebo for. It's still difficult to do the math, to do the statistics on that and prove it. So when they go to publish their side effect profile, they lean way towards the conservative side. And now, what's really helpful is you can say, okay, cool, what were the actual percentage of side effects listed? You're like, okay, so I get nosebleeds on my statin. And it's like, okay, we had 1,000 people and they had 3 reported nosebleeds in a month. Well, how many people have a nosebleed normally? 2. Oh, it was the statin and that one, and that's the kind of stuff that if you get to that point and you realize, oh, okay.
It makes you crazy.
Now that being said, one I don't have this one in the memory banks, but it's like 1 in several hundred people will have a bump in their liver enzymes when they take a statin because genetically they don't break down the medicine like everybody else. That's something to pay attention to, right? It's like 1 in 30 will have some muscle complaint, whether it's actually significant or not, or going to harm them in any way. And usually that's the group where you say, hey, if it's, what do you know? I feel like maybe my thighs are a little sore when I'm on the medicine. Go back down on the dose, switch statins, do something, see if that goes away. Could, if it was bad enough, measure their an enzyme that comes from the muscle to see if there's any damage. I've never seen one of those be positive. But at that point, it's like, well, even if we don't feel like this is causing any harm, what's the benefit to you of this statin? You've already had a heart attack and a stroke. I take the muscle soreness over the risk, right? Or I'm otherwise pretty healthy. Yeah, maybe it's not worth it. Even if it's not causing long-term harm, or you can get over it. And I put that in the patient score to try to give them the best idea of what their risk is, and then they can make that decision on their own. But yeah. So statins affect the way we metabolize our lipids, and typically you will see both HDL go up and LDL go down. And it's really predictable. I mean, they've got literally graphs showing the percent reduction each medicine at whatever dose you're going to expect. And so I can dose based on that. If anybody takes a statin, take it right at bedtime. You'll get way more out of it if you take it at bedtime. A lot of times you can reduce dose by taking it at bedtime because it's more effective. So I don't think I need to go into too much detail on how unhealthy cholesterol causes heart disease, so I'll move on to the next one. All right, nobody's gonna get this, but take guesses. What is that? It's a protein. It's a hormone. It's insulin. So I just put it up there. It's important to know that insulin's like a key to allow glucose to get into a cell. And the reason it's important is if glucose could just willy-nilly go in and out of our cells like it chose, we would probably not stay alive very long. Okay, so it has to be tightly regulated for a couple reasons. Think of it as like gasoline in your car engine. I use a lot of automotive analogies. It's this incredibly energy-dense substance that could cause great harm if it were not introduced into the engine in a controlled fashion, right? Glucose is not quite that bad, but it does over time do a lot of damage to the body. And so keeping it regulated in a very tight range is important to our body. One, because if it's too low, we can't function and we can die. If it's too high, it does something called glycosylation, which means it's really reactive with other molecules and proteins and things in our body that we need to not have glucose attached to it. And in particular, we talk about its direct coronary disease risk. Imagine glucose. Glucose molecules are going to directly interact with this layer here, glycosylate it, and cause inflammation and damage and scarring. Kind of similar to high blood pressure, but totally different mechanism. The scarring process creates the same problem. Glucose does that to all tissues in our body. It specifically is great at attacking small blood vessels and nerve endings. And so when you attack all the tiny blood vessels in the body, now you've described all the things that come along with bad diabetes. The visual loss is due to the retinal, the blood vessels in the back of the retina. The kidney disease, you can guess what this is. This is just all the blood vessels in the kidney. They're tiny. The small blood vessels in our toes. The further away you get from the pump, the more damage diabetes does, interesting enough too. So type 2 diabetes is now is becoming one of our biggest medical problems to deal with. And mainly because of how we eat and what we eat and our lack of activity. But take-home point on why insulin's at the top up there. The patterns of your behavior and how you eat affect your body's exposure to insulin over time. The more exposure to insulin a person's body has had over their lifetime, the more likely they're going to have diabetes. And so without periods of either fasting, so again, you don't have to be fasting per se either. If you don't eat a bunch of carbohydrates, so a person literally only had meat and fat to eat, which again, I'm not advocating for that diet necessarily, but I'm just saying if that's all you had to eat for a week, your insulin levels will be way lower than if you're eating a lot of carbs. Not that only carbs cause insulin secretion. Any meal causes insulin secretion, but it's your exposure to that insulin over time where that insulin signal no longer gets heard the same way it used to. The body gets tired of hearing it. So it takes more insulin to achieve the same goal. And over time, the pancreas creates the insulin. Over time, the pancreas just keeps producing more and more and more and more to get the same blood glucose achieved until at some point it loses control of that, and the average blood sugar starts to drift up and up and up and up. Initially, the concerns we have about diabetes and heart disease are due to that glycosylation, increased inflammation in the coronary. But there's so many other metabolic effects that are tied in to heart disease. So diabetes causes a derangement of a lot of metabolic things. It changes how we store our energy and how we use our energy. We don't get to use the energy it's not as readily available as it used to be when we have type 2 diabetes. So people have fatigue, they gain weight even quicker. And over time, those things like weight gain, lack of activity, and then the crave for more carbs because our body thinks it doesn't have enough glucose, right? Because the glucose isn't getting into the cells. It's a runaway train, and all of a sudden it's a slippery slope, and your A1C just goes whoosh. So it's really important to get a grip on that early. And as far as how medicine treats diabetes, up to this point, and up until the last few years, the only weapons we've had against it are medicines that increase the insulin. So it's like, it's treating the problem, but it makes it worse at the same time, right? Insulin is a weight gainer. The more insulin your body experiences, the more weight you'll gain on average. Now I've got a few medicines out there, including all the GLP-1s, the Ozempics and the Wegovy's and all that, that work in other ways that actually don't increase insulin and decrease insulin. The natural way of doing it is intermittent fasting, or really watching your carbs, making sure that the only carbs you eat are really high quality, no snacking, no sugared beverages, all that. So, last topic of kidney disease. So, some really interesting things about the kidney. They appear to be the most boring organ when you look at them. They're tiny, they don't look like much. But it's a filter, right? So this thing, it filters your blood. We can actually estimate how quickly it filters your blood, and one of these things that are in the calculator is something called the GFR, so glomerular filtration rate. And that is literally how much blood gets to pass through the kidney and get filtered in a minute. So a normal GFR is 60 or above. So that's 60 mLs of blood, or 60 cc's of blood in 1 minute can pass through the kidney and get filtered. So to conceptualize what the kidney's doing, imagine like a coffee filter, okay? And if you really want to improve on how much coffee, you have a big group of people to make coffee for, you're just going to get a bigger coffee maker, bigger filter, right? So the kidneys are tiny. What would you suppose is the filtration area of the kidney? Keeping in mind, it achieves a really large filtration area because these vessels get tiny, tiny. So you could cut open the end of those vessels, this thing called the glomerulus is where you filter blood. You lay them all out. In one kidney, how much surface area would you guess would you have? It's a meter squared. So it's huge. But to achieve that efficiency, and you got to conceptualize this, it does it within tiny vessels and tiny glomeruli, which are very susceptible to high blood pressure. Okay, so again, kind of like we talked about blood glucose, blood pressure range needs to be pretty limited to not do damage to that structure. Okay? And because the kidneys just don't filter blood, they do all kinds of other things, the impacts get pretty big, pretty quick. So kidneys do a lot of things. They keep our fluid in check. So they're actually the one organ mainly in charge of our blood pressure. So they tell how much water gets to circulate in our bloodstream. And if it's a lot, and we increase that fluid load inside the blood vessel, the heart has more work to do, right? So another thing they do is they direct the control of all of our electrolytes, so phosphorus, calcium. But when those electrolytes get deranged, they're the ones that end up being the deposits in the coronaries, right? So if your electrolytes are way out of whack, your calcium's way out of whack, all of a sudden your body has a hard time preventing that calcium buildup on the plaque in your coronary. Anemia is another one that people don't think about. So the kidneys are also in charge of the red blood cell mass. So red blood cells are what carry our oxygen, and roughly half of your blood is red blood cells. So if you take your blood and you spin it down in a tube, there'll be this big clear portion on top, and there'll be this red part on the bottom. Red part's all the red blood cells. Those red blood cells carrying oxygen, if they get diluted, like 50%, your heart gets to move it twice as fast. Not quite, but you get the idea. If you're trying to move oxygen around your body and you get anemic, your heart has to work harder. So if a person just lost a bunch of blood, but they got rehydrated and those blood cells were replaced by the fluid component, their heart would beat faster at baseline the next day. So the resting heart rate was 80, it might be 130 if you reduce their red blood cell count, 30% of what it was or something like that. So the heart has to work harder when you have kidney disease. And then the last part, I'll put together the inflammation and toxin buildup. So the kidneys and the liver are in charge of removing toxins. The type of toxins the kidney removes, if it stops working well, start to create a lot of inflammation. And so that's a problem. Inflammation creates more coronary disease. Inflammation is not your friend. So, any questions on those 4 big ones? Yep.
It seems like a lot of the risk factors are asymptomatic. Would that be a problem as far as detecting things like blood pressure? You can have blood pressure and not know it, right? Unless you take the test.
Right, so one of my main points is be aware of. measure your blood pressure. That's step one, you know. Avoidance is pretty common, you know, and I think a lot of times you come across disease states, people knew something was going on. They're just afraid to go find out. And everybody's got the reasons they make those decisions. A lot of them are actually pretty good. You know, but in the end, it's just not worth it. And, but you know, I'd say at the level these things are causing damage, yes, very unlikely to know something's wrong without like getting some lab test, some form of measurement, diagnostic testing. And we generally start that now at about age 30. So pretty big on prevention, the third, fourth decade of life for people. But I don't, those are patients I don't see very often, honestly.
So
Hard to get them in.
so the I feel good thing does not necessarily
Right.
carry the day.
No, not with this, not with the biggest killer in the US, right? So,
Dr. Dutton,
yes.
if you had to say you wanted your kidneys to be healthy, what would be the top, say, 3 things that you would do?
Definitely manage blood pressure if it's high. That one's a very rapid destruction of kidney tissue. Another one is hydration. People push that a lot, but it's true. If you have one disease state, so your kidney does so many different things, but it requires a fair amount of throughput to get that job done. You don't have to be crazy and be drinking so much water that your urine is crystal clear. That's not what I'm talking about. In fact, that may not be good for a person, right? But drinking enough where when you urinate, it's not concentrated. So a pale urine basically is like for a younger person, right? That's how I might tell them. Just hey, you work out on an oil rig or something, and you're whatever. We got some folks that do some pretty crazy jobs that just you forget your water for the day that you should have been drinking maybe 2 to 3 gallons because of all the sun you're exposed to, and you just don't drink all day, and you get in the habit of doing stuff like that. That's pretty hard on your kidney. Then I'd say the last would probably be diabetes at this point. When I think of the people with kidney disease that are my patients, it's usually high blood pressure, kidney disease related. There's a bunch of other stuff that you can't do anything about that's very rare. But those two, when you look at people on dialysis or folks that are really struggling, like we're having to dose adjust meds because their kidney functions poor enough to do that, it's usually high blood pressure and diabetes. So,
Thanks.
yep. Any other questions? All right, so we're nearing the end. You guys are doing great. This is really not the most riveting topic, but so this is where I live in the clinic most of the time. Is like I can get this stuff across to people over a couple of visits, and usually I'm not hitting them with everything. It's usually we're talking about your high blood pressure because you just got diagnosed or something. But despite having a large amount of training and convincing people to do things, I'm still not as successful as I would imagine. Does that make sense? Changing human habits is really complex and not one size fits all. And we can get past step 1A, knowledge, pretty quickly in most cases. Well, sometimes not. I have patients who just, they come in for alternative knowledge, I guess, and I just don't have it. I'm a Western medicine doctor. I have very strict marching orders. And what I learned, if I go outside of that, that's, you're not getting what you paid for, right? And I shouldn't do that because I'm not trained in alternative medicine, even though I'm not saying there's anything wrong with it. When you come to my office, it's like, I'll tell you the science behind what I think you should do. So you get past the knowledge point, and then the skills to make the change, it's usually not a problem. I mean, I can usually get people up to the point of, like nuts and bolts. What do we have to do? Are we talking exercise? Well, what do you got too much knee pain to do that? Well, what about this? Or your back hurts. So you work through these things and why they've avoided whatever it is you're trying to move on. You get to opportunity, that's a big one in this community, right? So if I'm seeing a patient, they probably have decent access to care. Now we lost MedRide this last week, so that access dropped immensely in the Medicaid population. But most of the time, access is not an issue. Social support, though, huge. That's the big hurdle for me. And I don't have a care manager in my clinic, I'm working on getting one. I really have to convince my administration that that money's worth it. But that's the barrier of care. People have a lot going on, you know? And convincing them to focus on their health when, like, they're living paycheck to paycheck, or, you know, they're a caregiver for a family member, trying to be creative in how to achieve these goals of just behavioral changes. Not something most surgeons or cardiologists are interested in hanging out and talking about. So that's why, and I think you guys gotta understand, like, people in primary care, like either internal medicine or family practice, like they're biting off this chunk. They're saying, like, I already got the medicine. The medical knowledge isn't the hard part. It's learning your patient, spending time with them and trying to convince them of what to do. And then once they decide they want to do it, next step is this motivation factor. And it's really hard. But I think, you know, one thing I keep coming back to with patients is I don't want to get the cart in front of the horse. So I don't want to start talking motivation when we don't have any understanding of the problem. Or I don't want to be throwing out how we're going to do it when they haven't even committed to the change. Smoking's a good example. Smoking is so hard to do, and you have someone come in your office, you're trying to convince them, and you're the 80th person to try to get them to quit smoking in the last 6 months. Every family member that means anything to the world, or anything in the world to them, has already told them, you need to quit smoking, Mom. You need to quit smoking, Dad. I can offer them support with medicines, you know, but if they're not ready to quit, or they haven't really flipped the switch of it's you know, it's this or this, that switch gets flipped pretty quick when someone has a heart attack. But and then if I push them too hard, I've lost my trust and relationship with them. So this right-sider kind of approaches for different people and things that just work. You can convince somebody, man, you can do something for 30 days in a row. Day 31 will get easier, I promise. And it will get easier from that time forward. Habit formation, so good and bad habits. Our brains are wired, it's important to get the point across that our brains are wired for reward. Again, we're made to feast and famine. We're made to be rewarded when we find the food. We're supposed to seek it, right? Our bodies are designed to seek food for days before we get food and have high energy while we do it, right? And our minds get more clear the more we fast. There's a lot of really interesting things that point towards you're not made to sit on a couch, right? You're not made to sit around and eat food that was poor nutrition but low cost and really high reward because it tastes so good. Once people can key into that, it's like, well, maybe don't, when you know, your change is not going to start at the cupboard, it starts at the store. Don't put it in your house. When you're weak, if it's not there, you're not going to eat it. Fill your house with things that are healthy, but not so tasty that you can't resist eating them. You know, some pretty simple things. Or put yourself in the path of more resistance. You know, commit to something you normally wouldn't do. Join a group of people doing something that you wouldn't do. It goes hiking. You know, you don't hike at all, and then when you go, don't spend all your time thinking about what you're going to eat that day. You know. And these things kind of like start to make sense over time. Like, well, that's what we're designed to do. You know, we need to get more back to what is the physiology designed to do. Try to live that life. You know. So yeah, I put this up there mainly to make you guys feel sorry for me because this is I learned all this medicine and then you realize like this is where the biggest change comes from is spending time with people, and this takes time, man. I mean, it's like. If I'm running late in clinic by an hour, it's because I'm in this column over here. It's not because I failed to describe why diabetes causes disease or something. We're still going to get back to your question, Schmidt. So the last question just of the whole thing is posed to be like, hey, so if this is the leading cause of death, what is your personal most overlooked risk factor that you could be ignoring? Maybe you could take that home today just to make sure you got all your T's crossed, I's dotted. Or you think, did something come up today that you haven't investigated with your healthcare provider or yourself Because they all are big enough items that they can cause a pretty big problem if you don't address them in 5 to 10 years, if they're getting out of hand. And that really, most people start to see things veer in certain directions in their 40s. And we don't, most 40-year-olds don't go to the doctor. So yeah, there's a missed opportunity of about 15 to 20 years if we could just get people started on their health earlier. But, so one thing I wanted to do, and actually let's talk real quick. Insulin resistance, fasting, diabetes, all that. Just limit me to like 3 minutes, right? There's a book, and a lot of people have already heard me tell you go read it. It's really boring. It's not written that interesting, but it's got some really good points. Jason Fung has written a number of books, but The Diabetes Code or The Obesity Code is a good book on talking about why is fasting so impactful with metabolic syndromes. And why are people so opposed to it? We've changed our behavior to adapt to a food market that is not designed for your health. It's designed for profits. To the point that there are many ingredients in the American diet that aren't even allowed in European countries. High fructose corn syrup is one of them. Someone basically engineered the sweetest, cheapest thing we could put in everything that would make people buy it, and it's terrible for us. Fructose is a sugar that our body simply wasn't designed to consume in large quantities. It was designed to consume it in fruits, but not in pop, not in our syrup, not in every single jelly you can buy at the local store, or pretty much all the candy that kids can get their hands on nowadays that aren't like chocolate and like they're all your sweet candies, high fructose corn syrup. And so we start that deranged metabolism in teenagers, and then now we've got, of course, everybody's experienced the generational effects of soda pop, and now energy drinks. So the new, and again, it's not only damaging because it's such a simple sugar or simple starch, but it's also something that our liver has a hard time processing and getting through it. And so we're seeing just unbelievable numbers of something that is now called metabolic associated fatty liver disease, which used to be just non-alcoholic fatty liver disease. And so what's going on there is that our fat's trying to process, or our liver's trying to process these sugars, and they're getting metabolized in the liver into a fat, stored as a fat over time, and the liver's not made to store fat. And that type of cell in the liver causes inflammation, and over time, that disease looks no different than alcoholic liver disease, where we end up with cirrhosis and liver failure. And some people have never really consumed much alcohol with that disease. But getting more common in diabetes, and mainly because of the quality of carbohydrate that we're consuming gets lesser and lesser. So going back to how our body moves that energy around, imagine the liver and the muscles have stored energy in the form of this glycogen. And that has a purpose of recharging us and being used fairly rapidly. Our fat is there for long-term storage. So if we have full glycogen stores and we go out and we engage in activity that's going to make us sweat, we're playing pickleball or something, right? And your body knows at the rate that glycogen's disappearing, it already needs to tap into the fat and start moving it along. So there's all these metabolic processes to move these energy stores around in our body. But when you sit on the couch and consume really high calorie, low quality carbs, they get stuck in places you don't want them, basically. So yeah, I don't know, sort of answered the question you had a long time ago. When you fast, it immediately it goes after that glycogen right away. And it changes those hormones and starts flipping them back and forth between catabolic and anabolic states, like we're supposed to. And it might take weeks of intermittent fasting before it gets really good. You know, like hey, when I fast, I just have no energy. It's like your body's not used to fasting. It doesn't know what to do. You know, it's run out of its short-term energy storage. It's like, oh, I'm supposed to break this fat down, you know. And so over time, it gets better at accessing that fat early on. And so the hormonal changes and switches that go on when we go into a fasting state, or we get really active. You know, like if we really start doing something like, you know, running a race or something, like a marathon. Marathon runners that are well trained, like their body starts accessing all their energy stores all at once very efficiently. But the opposite is true, they're also very good at storing energy stores. So like these folks that are doing like the crazy high altitude ultra marathons, the calories they consume in one stint, I mean, it's unbelievable. More than, I mean, they might burn more calories in one run than people burn all week at their job, you know, setting by me from a computer. So, all right, let's do some calculations. I'll get you guys out of here.
I just want,
Yep.
what is the optimum fasting scenario?
I don't think there is one. I think it's just the fact that we should probably teach our bodies to not eat all the time. And it doesn't necessarily have to be fasting either. It could be you're an active person and you just skip the meal. I mean, we've got, you know, someone who's burning 3,000, 4,000 calories a day at some, you know, active job. You come home late to dinner, you might already be fasting, right? And so it's that intermittent time of your body going, oh yeah, I gotta be able to use my fat stores when needed. But I think what I'm seeing are people that are just literally so sedentary that I guarantee they have glycogen stored in their liver from a decade ago. And it's and you can see those effects on imaging. You can, you know, and it's more common than you think. So, but I would say there's all this behavior-related stuff, and some people behave really well and just have bad genetics. You know, there are plenty of skinny, active people out there with diabetes. But you ask them about their family history, everyone in their family has type 2 diabetes by the time they're 65. Like, okay, well, this isn't going to work for you, right? We're probably going to need to use medicine. And most of the time we end up using medicine anyways. Like, behaviors are hard to quit, and I do not fault people for that. I have my own behaviors, like I love food, you know. I think I end up working a lot and having a lot of stress that just, you know, ends up you don't rest good, you don't eat good, you don't exercise, and it's not as much by a total choice. Some of us are in situations where we just, you know, we're doing our best, and I don't know. I really don't, or at least do my best not to judge people when it comes to anything behavioral. And that's. I think it's important, like if you guys have friends or family you're concerned about and that's why you're here or something, like you need to hear what it's like to be in their shoes and why they do what they do and why they're in the rut they're in. So the last thing I was going to do with you guys was work on just a quick, like I told you, if you Google AHA prevent calculator, you'll get this. And let's see, it's been a few years, but I got my labs done recently. So I'm 27. Turns out I don't have the healthiest cholesterol or blood pressure or BMI. But my GFR is pretty good. Remember so GFR is a measure of the filtering capability of the body and the kidney, and that's determined by a measurement in your blood called the creatinine. Creatinine is a byproduct of muscle metabolism that's pretty consistent from one person to the next. And so we can use that as something that we can determine, there's a calculation to determine this GFR. I don't have diabetes, I don't smoke, I am on blood pressure medicine, I'm not on a statin. I've never had this test done here, which is a different test for the kidneys. So this is one to look at protein loss in the kidney. It's usually initially done as just what we call a spot test or a random urine, so we can pee in a cup and test it. If it's abnormal, we usually want to quantify it better than that, so we'll do a 24-hour urine collection to see how much protein a person loses in a 24-hour period through their urine. And then this A1C, I don't have one of those, but A1C is, again, well, actually, I didn't explain this to you guys. So you remember I was talking about glucose glycosylates proteins, right? It goes in and it attaches to proteins in ways that are unhealthy and causes inflammation. It actually attaches to the protein that carries oxygen in our blood. So it doesn't discriminate. It attaches to just about all types of protein. So the oxygen carrying protein in our blood is called hemoglobin. It's what makes our blood red, so it makes our stool brown. Okay? It lives inside red blood cells. Red blood cells typically in a healthy person will make it about 3 months in the circulation before they get pretty ragged and the body will recycle them. Okay? So knowing that the glucose reliably attaches to the hemoglobin a certain amount of time, and knowing that hemoglobin persists for at least 3 months before our body recycles it, now we have a measure that essentially averages out our blood glucose for a 3-month time period. That's how it works. And so it's not the same measurement as the blood glucose we're used to seeing. It's in percentage. So the percentage of hemoglobin that's glycosylated. And anything above a 6.5 is considered type 2 diabetes. But depending on the lab you go to, like upper 4s, like 4.7 up to 5 to 6.5 would be considered pre-diabetes. Okay? And so we can correlate really closely that the damage done from diabetes to people correlates very well with these A1Cs. So for instance, you just got diagnosed with diabetes, your A1C was less than 7 at diagnosis, but things rapidly worsened and your A1C got above 8, and it stayed above 8 for the next 10 years, all of a sudden the likelihood of you having retinal damage and kidney damage is quite high, right? Get it above a 10, and now we're not talking 10 years, get it above a 10, we're talking like 6 months to 12 months. And so when somebody comes in, I look at that A1C back here, I'm thinking, how rapidly do I need to get this under control? See, here we go, diabetes, I'm like, side quest, right? So zip code is really interesting. So 80203, I looked some up before I came just to see how much of a difference we'd get. You can actually Google, let me do it real quick, because I can't find it. Zip code with the worst social determinants of health in Colorado. Wait, on the internet. I didn't. Is there a public or a private?
So it's the one that says LVPO Wi-Fi, that one right there?
Yep.
Yep, and then hit connect. And then it'll bring up a web page and ask you to accept our terms, and then it'll get you on.
Okay.
So it'll take just a sec.
Cool. Crowley County wins the prize.
What do you mean by that?
Tough to do, but statistically trying to determine what people would end up doing is saying I'm going to take these 2 zip codes and I'm going to take a patient panel from this zip code and try to build a patient panel from this zip code that have all the same health, and again, back in the day this was done manually, now AI does this for us. It does a much better job. And in quantities and numbers that are much larger than we can fathom. But so trying to pick a patient panel in Crowley County and a patient panel in Broomfield to look pretty much identical by numbers that I just put into this thing, and then look at who's healthier, and it's like, why is Crowley County not healthy? Everything, all this other stuff's the same, but these people have more disease. Well, again, you can't measure that directly, but we're putting that into a big bucket called social determinants of health, which involve a lot of things. Access to care, access to food, access to affordable, healthy food, just people's socioeconomic status. So how much money do you pull in your household every year? That'll determine what you do in your day. Do you have the time to go to the gym that doesn't exist in your county? You know, or do you have the time to go to the gym because everybody in your family is healthy and they're cared for and you don't have to watch over grandma? You know, grandma had enough money, she's in a nursing home, or, you know, I mean, there's all kinds of things that happen as that number starts to slide, so.
So when you said Crowley County, like you were moving that,
It's harder to be healthy in Crowley County than it is in Broomfield. If you live there, though, there's more to it than just that, right? Someone who lives in Broomfield also is probably a different person, right? But we, again, it's something in medicine we can't disregard. And so, but working here for me, I can't put my finger on it all the time. I can tell you my patients have a harder time accessing the things I'm asking them to do than my cohorts who are practicing in Denver. You know, all of my buddies from residency, we can talk, and what is it like, what are you trying to do for your patients, and it's totally different. You know, me getting someone a referral, much more challenging, because I gotta figure out how to get them an hour more. So,
How about the air quality in Denver though?
I'm with you. No, it goes both ways, right? Totally agree. We live a very privileged life in a lot of ways down here. That's why I live here, you know, but.
Can you give an estimate, or do you know if there is one, for the percentage of genetic impact?
That would take some time, and it'd probably be disease specific, right?
I mean, for...
Oh, a given location.
Or, I'm not talking about location, I'm talking about cardiovascular disease.
So yeah, for the most part, there are a lot of studies in the past showing that there was this large race-based component, which has been, that's, you know, completely, there's a lot of holes that got poked in that one. But genetic, from where you're at in the world, like where your family originated from, there's quite a bit of data on that that's coming out from things that are scientific and some things that aren't, like the 23andMe stuff, right? But again, there still is a genetic component. I'm not saying there is like no genetic component, but more about the genes that are passed on in a closer time frame, like your actual parents and grandparents, and how when those chromosomes mixed, what it came up with. And that's the case for many genetic illnesses, diseases, right? It's kind of like, I'll give you a good example, would be like hemochromatosis. You know, it's a reasonably common gene in the pool, as far as like 1 out of 10 people might be a heterozygote, meaning they have one gene, it doesn't cause a problem. But that means when 2 parents get together, if both of them have it, there's a 1 in 4 chance that an offspring will be homozygous and have a problem. And so probably more about that genetic.
Okay, and when you reference 23andMe, are you talking trauma? Is that what you were referencing?
Oh no, 23andMe I think is just like it's one of those you send like a sheet study and they tell you all about your genetic,
Oh, okay,
you know.
okay,
And again, I have patients bring those to me, right, and say, what do you think about this, doc? And it's like,
gotcha.
there's very few tests here that have been validated to prove anything. And you know, just recently I had one that was like a question about thrombophilia. So that's like a disease state where you have more blood clots than the next person, right? And my parent had a DVT, and what are my odds of having a DVT? Now I did this 23andMe thing, and it says here I've got like this gene for thrombophilia, and I couldn't answer. I had to go look that one up. And right now there's not enough in a link between that genetic state and having actual thrombophilia. And so it's like, why would you give someone that information if it doesn't actually change anything? It's going to make them worry about nothing, right?
Right.
So,
Thank you.
yeah, for sure. So let's finish this online calculator. So, can't remember if that was that the one that we just, that's 8176. So I think this one is like Broomfield or somewhere in Denver. So we'll be able to change that on the next. So calculate the risk for me. A 10-year risk of cardiovascular disease of 3.7 versus 30-year risk of 22.6. And those are not bad numbers. So this is why you got 10, you got to, you know, take this with a grain of salt, right? People still die of heart attacks that aren't all that unhealthy yet. I don't know what the next 10 years of my life's going to look like, but so let's change some stuff real quick. Again, this is the one I was actually interested in because I didn't see it was, sorry, 76, 8176. Let's see if it even, so a percent shift. Let's change some other stuff. Like let's give me diabetes and make me a smoker and raise this by 10. That was a huge jump. Now, let's see, I'm still 46, right? So I'm 46. And there's 2 of me. Only one of us is going to make it to 76 without a heart attack. Let's see. And don't let your mind think linearly when you see these numbers. It's not like this linear worsening of risk. It goes like this, right? Another thing I'll put in here is like if we just increase this by a decade, you gotta keep in mind, now we're talking about an 85-year-old person when I calculate the 30-year risk. It didn't shift as much as you might expect. So there's some scenarios you put in here that actually kind of reassuring, believe it or not. And the other thing I'll point out is come down here. It's going to show you, at least in a 10-year risk category, what is high, what's normal, what's low. Like, what should concern me? And those are based on the age you put in, right? So it's changing that risk category based on the age that you're putting in. So kind of fun to tinker around with, and if you guys identify some risk factors that if you change them to something better, you see a big difference in that 10-year or even the 30-year, then maybe that's what you focus on, right?
Does it do any good to take anti-inflammatories like garlic, red cherry juice? I mean, a lot of this stuff causes inflammation if you deal with the inflammation.
I think that most of the people who ask that question already don't have a problem, because they're interested in, so the inflammatory lifestyle is more of the, where the meat, I shouldn't say meat and potatoes of the problem is, where, the majority of the problem is like, folks are living, like their inflammatory factors are coming from really processed foods. Bad habits like drinking, maybe even drug use. But that being said, like, most of the time you're asking those kind of questions, you are talking about things that can make a small improvement, but they're icing on the cake. And I'd say out of all the things a person can do that's, like the real big bullets are like exercise. Exercise is a massive one. If we could engage activity on a daily basis, wow, you could do a lot of bad things as an active person and get away with a lot, so.
I didn't really hear you talk very much about stress today.
No, stress is a big one, right? So, and how does that work? So stress relates to probably cortisol levels, and sleep. So rest and repair. So that inflammation we're talking about also could, we have inflammation in our body and we're designed to have some inflammation. We have mechanisms of addressing it. But a lot of those mechanisms work while we're resting. And the other thing is, the behavioral column over there, it's not even worth talking to a patient who's not getting good rest. They're just not, our brain, at a certain point when cortisol is kicking in and we're in a stress response, we are not interested in what's going to happen tomorrow, or 10 years from now, or 30 years from now. Our mind is designed to deal with the present. And so that's important too. So when we talk about like, can you measure the impacts of things like
A mood.
oh, what's this here?
A mood, which is very stressful.
Yeah, no doubt. Any life event, right? Life-changing events, losses are a big one. Losses affect our sleep. Anything that can affect our sleep because we can't go to bed because something's worrying us. But again, that gets into that social determinants of health, But we have to also consider we live in a very even at the worst in Crowley County, we're living a pretty nice, I mean, like, at least most people have pretty good access to the things they need. It's just across the board, if we all make bad decisions, the ones that live in those communities probably get punished harder than the ones that don't. Because their access to things when they need it are less, right? It's harder to get the things you need, and if you're making bad decisions, you're gonna get punished more in an area where resources are limited. Sorry guys. That being said, what was I trying to think of? On the other side, trying to quantify like meditation, and thoughtfulness in a way that brings calm to you, whatever it is for you, whether it's meditation, going for a walk in the park, or listening to some really awesome music, or whatever it is. Engaging in activity that truly lowers blood pressure, lowers your pulse, relaxes you. That's different than watching Friends and eating, popcorn or something, right? So there's these intentional activities that, science is going to have a hard time quantifying the improvement in someone's health, but I guarantee you it's there. And that's mainly because of the type of rest your body gets when your cortisol drops, when hormonally you're relaxed, and when your blood pressure drops. And versus the opposite of that, of living a stressful life where you're in this go, go, go mode all the time, and your average blood pressures are pretty high because your body's responding to the stress appropriately. It's not, but again, by design, we're not made to be in a level of stress for months. That's not our design. And if we do that, it changes our physiology, and all of a sudden we're starting to develop things like high blood pressure. Insulin resistance, that's an interesting one, right? Like, so stress increases insulin resistance. And because of cortisol, as one of the main things. It's not the only thing, but I have to say, like, cortisol is a great hormone if our body were using it appropriately. And so building in our time so that we're stressing our bodies appropriately and then letting them rebuild. That's how you get strong. But you'll get weak by stressing it and never giving it rest. And everywhere there is in your body, up here, here, so.
And the impact of pain.
Impact of pain's a huge one. Chronic pain's a killer. Just like people say stress is a killer, chronic pain is a killer. People don't live long, or as long as they would have if we can address that pain appropriately. Unfortunately, similar to other things like diabetes, it's like a lot of things we have to treat pain cause disease also in a different way. So it's something that it's really challenging. Chronic pain is one of my most challenging diagnoses, guaranteed. And there's a lot of people who have chronic pain in this whole county. A lot of hardworking people, a lot of people that had some bad things happen to them. And, so yeah, our whole clinic, like, we work together. That's one of the topic that comes up a lot because we're all, it's just hard to treat. So, cool. All right, guys, cool. Well,